right, welcome back to Bayou Time. Again, we're visiting with Dr. Craig Walker, world-renowned cardiologist, also the founder, president, medical director of CIS. And we were talking, a lot about the innovative procedures he's performed, but also his partners as well at CIS and what they've done. And, we failed to mention, your involvement in helping to train other doctors across the world and the region in promoting, better treatment of cardiovascular disease. And you're also the editor of Vascular Diagnostics, I believe it is.
Vascular Disease Management,
okay.
Also of Global Vascular Digest, 2 journals dealing with peripheral vascular disease.
Excellent. And I assume, doing that, and we've covered here, Martin's covered for years, your innovative procedure, and I believe there was one where you did one actually live, and it was streamed across the world. But what else are you guys doing at CIS, and you specifically, to help promote, the prevention of these terrible diseases and also the saving of lives and limbs of individuals?
Sure. Well, the knowledge base around peripheral vascular disease has increased tremendously, and it's done so at an unbelievable pace. So we're trying to really get that information out. Historically, people presenting with critical limb ischemia simply were offered amputation. That was all that they were offered as an option. Now, more than 95% of those people were able to save those limbs. So to try to get that message out, we've put together conferences. Our big conference umbrella is called New Cardiovascular Horizons. And each year we have a 5-day conference immediately following Memorial Day in New Orleans that people come to from around the world. In addition to that, we put on 17 one-day regional meetings at various spots around the United States. We have one in Minneapolis. We just came back from one in Miami. But we put these on all over the United States. These are one-day seminars aimed at training physicians about what's new in the peripheral space and how to better treat these patients. We put on a big international meeting in Latin America and 3 in China. So it's a lot of travel and a lot of work with this, but we're really starting to make a dent, in my opinion, in how this disease process is treated. We first had to show people what can be done. And it's very interesting, once they see these kinds of results, there's a lot of pickup of these techniques.
But before y'all began to intervene, I guess, and spread this information and new technology on how to better treat these things, what was the norm for other places in the world on how to treat this type of disease?
Yeah, this disease was often allowed to go really far, to the point that people simply had to get major amputations. Now even people presenting with gangrene, the vast majority of them can get by, if they require an amputation at all, just by losing perhaps a toe or something like that, which is very different than losing a whole limb. It allows much better mobility. The patient is certainly much less handicapped with that. So we think this is very important. There's, of course, much less pain, much less suffering, and they do better with it.
What is the life expectancy, not to scare anyone out there, but we're here to make sure that we get it out there so people can get checked appropriately. But, if versus losing a toe or losing a leg, I mean, does the life expectancy decrease if you've lost a limb?
Yes. Major amputations are associated with a dramatic decline in life expectancy. It's very difficult to totally quantify that, but we know that people who lose a limb from atherosclerotic disease or from buildup of blockages, it's very different than a young person who loses a limb because of trauma. Okay. That young person often can train themselves, can be fitted with prostheses, can ambulate and do very well. But older people, when they lose their limbs, often cannot rehabilitate. So people who have, for instance, an above-the-knee amputation, more than 1/3 of those go straight to a nursing home and never leave there. Wow. Okay, even below the knee, high percentages of them do that. So we have to do a better job in terms of trying to, A, prevent the problem, secondly, treat it early if we can, and C, even in advanced cases, have advanced treatments so that we can help these patients. And that's indeed one of the things a device like Turbo Power allows us to do. It allows us to better clean out these vessels. We're using laser energy to to actually go in and vaporize that obstructive plaque and clot rather than simply stretch it with a balloon, because as you might imagine, when you go in and stretch with a balloon, there's elastic recoil that occurs, much like a rubber band, because you're not removing the tissue. Now, even minor increases in the size of the vessel affect flow tremendously because it's related to the fourth power of the radius. As we make just little bitty changes in terms of the channel size, flow goes up an awful lot. But certainly the best of all worlds is if we can make a nice big channel without injuring the vessel, and that's our goal.
So is the first step in treating, what's the first step in treating PAD?
First step is making the diagnosis,
Okay.
suspecting it, thinking about it. Once we suspect it, then it's a very easy thing to pick up. We first would check pulses in the foot. If not there, then we would do what are called segmental Dopplers. We'd put blood pressure cuffs on the legs and listen for sounds. And with that, we can find out if someone has a blockage or not. Now, that doesn't tell me vessel size or characteristics or which vessels. It just gives us an idea which parts are getting enough blood. Following that, there are all sorts of things that we can do. We can do a duplex scan, which uses ultrasound from the outside. That can be very good as an exam, or sometimes we may use a CT. And a CT can, with a dye, can tell us what's blocked where, if a person has an aneurysm. So there are a whole series of things that we can use to then make the diagnosis. And then, of course, if we need to treat, there are many treatments available. We perform interventional treatments, but there are also excellent surgical procedures that can be performed for people who have blocked arteries. My real fight is not whether they have a surgical procedure or an interventional procedure, it's that they get treated. Okay, the big problem, in my opinion, is that many of these patients don't get treated other than to simply have amputation. And I think we have to do better than that.
And you mentioned earlier that sometimes it often goes untreated because individuals suspect, oh, well, maybe it's just my back or maybe it's just my knee because I've had a bad knee for a long time. Or maybe they just are scared of that diagnosis. And I guess what you're trying to say is, you know, come see us because it's not necessarily the death sentence unless you just leave it untreated, then it is.
It should never be a death sentence if approached appropriately. It really should not. And, you know, the other reason some people just don't recognize it is they don't feel it. People with diabetes, often the nerves don't work very well. So a leg may be in a world of trouble and they don't feel it at all. And that's a very important thing to understand. Just because it doesn't hurt doesn't necessarily mean it's okay, because it may well be that those nerves are dead and they can't feel.
So as you mentioned earlier, certainly if you've been diagnosed with diabetes, you want to be getting checked to make sure that it hadn't progressed to PAD level.
Diabetics are the people at greatest risk with limb loss, for sure.
Does it matter what type of diabetes that a person has?
It does. Type 1 is worse than type 2, but they're both of them represent a lot more risk than the other risk factors. And that is followed by cigarette smoking.
Okay. And I guess that's something that not a lot of people realize. But if you have chosen to smoke, your risks go up substantially for cardiovascular disease, correct?
Absolutely. And in terms of peripheral vascular disease, the things that smoking really raises dramatically are abdominal aortic aneurysms and popliteal artery aneurysms. Why those areas, don't know. But that's clearly statistically been shown. If you're a heavy smoker, much more likely to develop abdominal aortic aneurysms and aneurysms in the artery behind the knee joint.
So that is, you know, in addition to the exercising that you mentioned, smoking cessation is something that needs to take place, and you need to do it soon.
Crucial. And here's the other thing I think a lot of people don't realize. The younger you start smoking, the bigger the problem. 10 cigarettes taken at age 6 is very different than 10 cigarettes taken at age 60.
And why is that?
Because it has so many more years to work. It's like putting money in a bank and interest occurring. Same is true in terms of atherosclerosis. You create that injury early on, and then it allows it to continue becoming a problem. So I really urge young people to avoid cigarette smoking and you know, to take care of themselves. Right now in America, we have an epidemic of diabetes. It is estimated that by the year 2020, if present trends continue, almost half of our youth will be glucose intolerant, if not overtly diabetic. That's really scary.
Yeah.
And so we have to do something with that. We really have to address this issue because it's resulting in a whole new series of diseases that could really become a huge problem.
Let's take another short break, and then we'll wrap things up with Dr. Craig Walker, who's been kind enough to visit with us for quite some time here on Bayou Time, providing us with a lot of information that we should all be paying attention to regarding cardiovascular disease and specifically peripheral diseases as well. So stay with us. We have more right here on Bayou Time.